Hi, my name's Dr. Anna Locke. I'm a palliative medicine consultant. I work in Sandwell and West Birmingham. And today I'm going to talk about how we help our patients plan in advance for things that we can really anticipate is likely to happen because of their medical condition. And that's really about helping our patients to get the goals they want. Thinking not so much what we can do, but how we give them information so they can make really good decisions about how much or how little intervention they want and what other aspects of their life they might need to put in order. So why is this important? Well, if we think about it, we all die, we know that, although we don't like to think about it very much. And actually 1% of our population at any time is in their last year of life. And if you go to any hospital in the UK, about 30% of people in the hospital on any day are in their last year of life. Now that's a lot of people who have a lot of interventions which increasingly happen to them as they get more unwell. And those may be things they don't actually want to happen to them, or they may be things that you find yourself having to do to them that you think maybe this isn't going to help them. And it would be really nice for us only to do things that are likely to benefit people. And increasingly, as our population ages, this is going to become more and more important as we try and tailor what we do to what people's goals are. And we know that the more we work with our patients to get a shared goal and a shared ambition for what care they're going to have, the less complaints we have, the less unwanted interventions, the less hospital admissions as we get into the last year of life. And actually, we have less complaints and people have better bereavement outcomes because they know they've done the right thing for the person they love. So we need to do the right thing for the right patient at the right time. What I'm going to talk about during this session, I'm going to frame it around a particular patient called Raj, who's in his 70s. And Raj has lived for a long time with heart failure. It's become part of his life, really. His family have managed his heart failure, he's got diabetes, and he lives with his adult children and his wife, and there's grandchildren in the house as well. And unfortunately, over the last couple of years, he started off with prostate cancer, had the normal hormone modifying treatment, but now he's starting to struggle with his treatment. The prostate cancer has escaped the hormone modification, and he's been through chemotherapy, and he's really struggling and becoming increasingly frail. And I'm going to use him as the frame, really, or the prism for us to talk about how helping him and his family talk about the future and their wishes might be able to improve his experience of end of life. When we talk about advanced care planning, really we're talking about how do we anticipate what is going to happen? How do we get a shared understanding with the patient and their family about what their goals of care might be? And how we make sure that the care they get is consistent with what they believe and what they wish to happen. Now obviously you might have some people who say, I don't want to die. And someone like Raj, actually we know because his prostate cancer is progressing, because he's already got established heart disease, and in fact he may have, because he's got an implantable defibrillator in, he may have already previously had near-death experiences where the implantable defibrillator has started again and started his heart again. And so he might have got some experiences which is making him think, actually, if I'm thinking about the future, I've cheated like a death once, maybe I can do it again. But actually, we as clinicians understand that at some point he will not recover. And actually, the likelihood is he will understand that as well, especially as he's becoming more unwell. So as a palliative care doctor, everybody I look after is going to die. And most patients we look after have a prognosis of up to about a year. Now, I do sometimes look after people with longer term prognosis, say somebody who's got a particularly painful malignancy that's likely to respond to treatment, and they've got a lot of symptoms, say someone with leukemia or a cancer which is going to have treatment, they might live longer, or someone with an unpredictable trajectory but is likely to die. But for most of my patients, when we're thinking about the future, often we're thinking about actually how would they like to die, where would they like to be? And for someone like Raj, giving him that opportunity to think about who would I like to have around me? Would I want to be in my own home? Would I want to be looked after by my wife and my children? Might they need extra help to manage that to happen? Which other agencies could come in and help them? Would I want anybody? Would I feel comfortable with them? And to explore in my role, often what I'm doing is exploring what do we need to facilitate people's wishes? How might they be comfortable? What do we have to do to put in place comfort measures such as pain control, other end-of-life care measures. But to do that, we really do need to anticipate that this person is dying and talk about it. And it might be difficult culturally. There are many people who find talking about dying hard, and that can be doctors and nurses, and other allied healthcare professionals, and patients' relatives, and the patient themselves. And sometimes we do have to go around things sideways. But actually, as doctors, we are trained to recognise when people are unwell, when they might deteriorate. And part of our duty of care is to help people have conversations which might help them get the right treatment. And often something people talk about is quite important is where they are, what that choice might be. And we know that people who, once they get into hospital, they're much less likely to die at home, or die where they want to die. Now, that might be a hospice, or it might be their own home, or it might be a nursing home, or it might indeed be an acute hospital if it's somewhere that they've been a lot. But wherever they are, we need to make sure that the care they get is the right care. So when we think about planning in advance, what a lot of doctors or a lot of clinicians do is they think about CPR or a treatment escalation plan. And that's very much because that's what we do as doctors. We think about doing things. But actually for many families, that is not the big issue. As doctors, we don't want to do things which don't work. And actually, as a young doctor, I spent a lot of my life resuscitating people who were clearly dead. And part of the reason I came into palliative care was because I really could see that that was a waste of my energy. It was a waste of the team who I was with, but also it felt like a very bad thing to do to somebody when we knew it wasn't going to work. So as doctors, yes, we do need to think, will the treatment we are recommending work? So is this person likely to benefit from resuscitation? That should be an aspect of planning for the future. And as a palliative care doctor, I regularly have conversations with my patients about what will help and what won't help. But I'm not asking them, would you like to be resuscitated? I will be setting out whether actually at that point in their life, would that kind of intervention add to their quality of life? And do they have any particular beliefs or wishes about it? Now, I do have some patients who, if we're talking about Raj, say, he might have a particular belief about resuscitation because of something, his ICD had gone off before, so that's a form of resuscitation. Or he might have seen something on the TV, or he might have lots of people, say, praying for him at the temple, and he might start thinking, well, actually, if I'm not resuscitated, is that like giving up? And exploring that is very important, because obviously, if someone says, if I want to be resuscitated, and we as clinicians say, oh, no, we're just going to not do it, that can cause lots of discomfort, and actually we all need to be on the same page with the same goal. And the same goes when we're talking about treatment escalation planning, whether that's going to intensive care, whether that's someone should have non-invasive ventilation, even something as possibly minor as intravenous antibiotics and fluid is an intervention that we're doing to somebody, and they may not want it. It can be very uncomfortable. So actually deciding with our patients, would you really want this? But also, is it something that is going to add to their care? So, for example, when Raj has chemotherapy, if he gets a neutropenic sepsis, so he gets an infection after his chemotherapy, his likelihood of benefiting from intravenous antibiotics may be very great. So when we're talking to him about that treatment escalation planning, that would be, you'd have to give that information as are likely to benefit. However, if his bone marrow is now very full of cancer, and actually he's got very poor immune system, and his whole body is deteriorating, actually his chance of getting significantly better when he gets that overwhelming sepsis has gone down a lot. So again, he needs to have an opportunity to think about, actually, if I get really unwell this time, what would I want? And that will depend on the stage of his illness. And as doctors and nurses and allied healthcare professionals, that's the information we can help them with, so that Raj can make his decisions with his family about what he would want. And the other thing that I really see in my job is that this decision making changes as people get more unwell. So for Raj, when he didn't have his prostate cancer, he had his ICD and his heart failure was managed, those set of decisions about where we go, how high, how much intervention will be very different from where he is now as his cancer is progressing. So if he was at home, I'd be wanting to start conversations about whether he still wants to have his implantable defibrillator switched on, whether actually it might be a time to switch that off. And I might do that in cooperation with the heart failure team who know him well, his community heart failure nurse, his community palliative care nurse. And at the same time, we would be opening up conversations about where he might want to be, what support his family might need, and if he did get an infection, how we could manage that. So we do have some tools in our armoury for helping us make these decisions. Depends where you work. There's a big national movement going around trying to promote this idea of advanced care planning. Every area will have their own solution. It may become a national one at some point, but the important thing is the conversation and helping us, guiding people through these decisions. So there's something called the Respect tool, which might be all over the country at some point, but that's really an advanced care planning tool that includes treatment escalation parameters and CPR decisions. In Sandwell, we have our own localised form which incorporates CPR decision and treatment escalation. But so commonly it'd be things like, should they have antibiotics? Would they want to go into hospital, ITU, ventilation? But what you'll find is actually different conditions need different decisions. So if I'm looking after someone who's got a leukemia and they've got very low platelet counts and are very likely to bleed, I will make sure that my anticipatory plan includes what happens if they bleed. Whereas somebody who doesn't have that risk so greatly, I might not major on that so much. Maybe someone's at risk of seizures, I talk about that instead. And in the acute trust, this process will also be undergone, and each trust will have their own solution for treatment escalation planning and DNA CPR. And again, every time the family and the patient need to be involved. Obviously, if a patient has capacity and they do not want their family or their next of kin involved, that's fine, but it can set us up for failure in the future of people's families and the people they love and who might make decisions when they don't have capacity, aren't aware of these things. So when should we talk about the future? Now, it will very much depend on how unwell someone is. Now, most people do some kind of advanced care planning. I've written a will. I've talked to my husband about what I would want if I had a head injury. I would talk to him about if I needed to be ventilated. I know I'm unusual. I'm a palliative care doctor. Maybe I've seen a few different things from other people. But as we change in our life and our stage of life, and that might include diagnosis with a serious condition. So for Raj, his planning for the future will change as he's got his cancer. So he might be starting to think, actually, I need to think about what's going on. People who are admitted to care homes, that's a prime time for doing advanced care planning, because actually people only get admitted to care homes if they've become more unwell generally. And there's been a big push to try and open up that conversation as people go into care homes. But sometimes that's even a bit late for them because maybe they've lost their capacity to make decisions. So ideally, when we start talking about the future, we should think when people actually have capacity to make that decisions. But that's sometimes when we have to use proxy decision makers, people who think, actually, can you help us? What would they have wanted? How do we make sure we give their wishes as best we can within the limitation of their health problems, and also what we actually have available. I've had patients say to me, I want to stay in my own home, but I must have care 24 hours a day because I live on my own, and we cannot do that. The most we can do is a set number of visits every day with pop-ins in between. So we have to be realistic about what we can achieve. For Raj, his prompt to have some conversations about the future and do this anticipatory planning might be a couple of hospital admissions with infections, or it might be that his oncologist had recognised that his treatment is his cancer is escaping the treatment that he's giving him and made a referral to palliative care. But the actual conversations about what he wanted could be done by the oncologist, it could be done by the palliative care nurse specialist, it could be done by an empathic district nurse who knows him well, or a heart failure nurse who's been looking after him for years for his ICD. And sometimes these decisions have to be the actual what we can do, what is possible, which is what our patients need to know. For Raj, he would need to know, actually, if my defibrillator goes off when I'm dying from my prostate cancer, will that save me? And the answer will be no, because he will be dying because his whole body is failing. But actually, he might need to hear that from his cardiologist, who he trusts and has an ongoing relationship with. when you're thinking about starting conversations, it's always good to have in mind for actually what is this person's prognosis? How long do we think they have? How urgent is this decision? So is that person going to be dead? So when I'm seeing Raj, if I'm seeing him at home or in hospital, I will be thinking, okay, how have things changed over the last couple of weeks or months? What's the future likely to be? Because if I think he might be dead in the next couple of weeks, the speed we might have to have these conversations might speed up. Then that might be, okay, do you need carers in? Do you need equipment? Do we need to make sure there's a form in your house so that if you do fall over and your wife calls a paramedic, actually, if you don't want to go to hospital, let's make sure it's documented and in your home. And that form can be done as someone leaves the hospital, but it can also be done at home. And finally, I feel like I've given you a bit of a whistle-stop tour. I haven't talked about statistics, I haven't talked about probability of surviving from CPR, because there's a lot to remember. I think the important thing is when we are looking after people, we need to be anticipating and working with them about what their future might look like and give them information in a way they can understand to help them make decisions, whether that's about whether they want to start making funeral plans or whether they should write a will or whether they actually want to have that conversation with the person they love about how much they love them. Never mind whether they want to go to ITU and things they wish they'd said. And our job as clinicians can be to be those guides, to give permission, to say it's okay to talk. It's not taboo, or if it is taboo, let's just open up this box for a little while and have these conversations. And they can be the most rewarding conversations in the world. And then we need to share the information with people's permission. Make sure that if someone does talk to you about not wanting CPR, that you do the form, that form goes home with them and that a primary care clinician knows about it. And if people's wishes change, we change the form.